Welcome to Decoding CTO case 33. So this case is a chip CTO PCI which we have done with Impella Assistance. I'm Dr. A. Sharath Reddy, Interventional Cardiologist, Medicover Hospitals, Hyderabad. My patient is a 71-year-old male, diabetic, status post PCI with stent to LAD, ramus and distal RCA in 2006 and 2012 with moderate LV dysfunction, and he was also drug defaulter and currently presented with recurrent episodes of acute coronary syndrome with a decompensated LV failure leading to 2 admissions in 15 days span, and patient was stabilized medically and discharged with medication after that. After second admission, angiogram was done, which showed significant changes. His TROP and NT-proBNP was elevated. This was the echo at the time of admission, so he has severe MR. So one patient was in a decompensated failure as well as hypotension, and we can as well appreciate high PA pressure, which is nearly around 78 plus 10, 88 millimeters of mercury. But this MR was quite dynamic. With medication and rest, MR reduced, and whenever patient exerted, MR increased to severe and leading to hypotension and subsequent increased breathing difficulty. This was a coronary angiogram done. We can see the patent LAD stent and ramus stent is occluded completely, and ostial LCX is tightly deceased, nearly 99%, and RCA is total occlusion, chronic total occlusion, and there is also a stent here. So there is also stent here, so it's a kind of instant CTO. So high syntax score, high Euro score, high SDS score, and also high chip score. So in a heart team discussion, as the MR is dynamic and coming down with initial medical therapy, so we took a decision. We offered PCI, protected PCI to the patient, and we can see here it's a JCTO score for right coronary artery CTO. Cap is clear, only thing is length is beyond 20 millimeter, as well as it's a calcified lesion which we can appreciate here, proximal to the stent. So stent is only located in the distal part of the CTO segment, extending up to the crux. So essentially it's JCTO score 2, and this is the chip score of patient. Chip score is 10, and you can see whether patient needs a protected PCI or not. So since age is beyond 70 years and is diabetic, in decompensated heart failure, presentation being ACS, and also there is a distal left main bifurcation, and there is calcified ostial LCX, and he might need retrograde for RCA through the septal collateral, and he might need even guide extensions to the RCA as it is very calcified, needs more support, and as well as atherectomy devices. And more importantly is he has severe MR and very labile MR with ischemia, so with moderate LV dysfunction. So since all these were present, we thought we'll go ahead with a protected PCI for this patient. And coming to the wiring strategy, so this is a good collateral to the septal to septal PDA collateral, so which is useful as a retrograde interventional collateral. And most important here is, since patient had a stent in the CTO, this is a distal part of the CTO, there is a stent located, so and this acts as a good marker. So what we can do, just park microcatheter proximal to the proximal cap and then switch to a directable wire like Gaia 2 or even Gladius we can take. So, and direct it in two orthogonal views, first into the proximal part of the stent, followed by further directed tracking of rest of the instant CTO to come out at the crux in two orthogonal views from the middle of the stent. So wiring is much easier because stent acts as a marker for antegrade wire escalation and directed tracking of CTO. So these are the two challenges: hemodynamics, poor hemodynamics, which we can overcome with Impella support, and poor guide catheter support for RCA PCI, which can be overcome by anchor balloon or guide extension. We did PA catheterization before procedure, so his PA hemodynamics are okay with the CVP of 4, and so Impella CP is inserted, and then we started Impella CP with a good flow, and this is a baseline angiogram. You can see there is a tight hostile LC exhalation. So we did an IVUS from hostile LAD just to understand where the stent is ending in the hostile LAD to decide on strategy of bifurcation. So as the stent was extending up to ostium, you can see there are a couple of struts here, so in the ostium. So we decided to go ahead a kind of mini crush strategy in this case. So we did LMCA bifurcation PCI first, kind of mini crush strategy. So dilated LCX, then did a kind of kissing balloon followed by IVUS, and you can see in hostile LCX there is 360 degrees of calcium. So hence we used a flex dome to create cuts in the calcium, which we confirmed with IVUS subsequently, followed by we did a stunting from LM to LCX with mini crush, part, kissing and repart. You can see this is the final result, which is good. We deliberately left this ramus since it was a very long stunt and it's a diffuse instant stenosis, and also it has a good collateralization from LAD and this ramus. We decided to leave it since we have to do a lot of work on right coronary artery. So this is RCA dual injection. You can see we took a JR as manipulating Amplarger guide with an Impella inside is slightly difficult, so that is the reason we took a JR catheter. And you can see in dual injection this is a CTO segment and the stent is sitting up to the crux of the RCA. So yeah, this is Corsair, which is placed before the proximal cap, or as already explained, and then we took a directed tracking wire, that is Gaia, and used this stent edge as a marker and navigated wire in two orthogonal views there, and subsequently, as this wire was not progressing, so we switched to Gladius Mongo, which is again 4.5 gram tip load, and you can see this wire we navigated into the stent, and later it subsequently navigated till the crux and into orthogonal views, and it stayed in the middle of the stent. Once Gladius Mongo crossed, we advanced Corsair into the distal RCA and followed by wire exchange to a workhorse wire. So you can see here, and we tried sending a 1 mm balloon through the guide extension, but we couldn't cross with 1 mm balloon, and then we had to take a laser, excimer laser, and we did excimer laser through this CTO. You can see here up to the distal cap. Since it is an instant CTO, as well as CTO is extending up to the distal cap, doing excimer laser will give us good final lumen areas, as well as crossing into PL becomes much easier once we ablate the tissue here. So yeah. So next, at this level, actually patient went into severe hypotension, and we just checked, left system, and left system was normal. And you can see here there is VA uncoupling, and as well as complete loss of contractility, which can be appreciated even on fluoro as well. So we thought mostly it is because of the guide extension. So that's what we discussed in the initial planning. So prolonged guide extension into these vessels in such a poor hemodynamic situation can cause hypotension, and patient may go into vicious cycle of deterioration. Since there was Impella, we could able to manage mean MAP, though there is a VA uncoupling. And patient CVP at that point of time was 6, so we infused IV fluids to bring CVP back to 10 to 12. And you can see now the contractility is improved after some fluid load, and we can also see a good flow into the RV branch. Now we crossed into the PLVB by using a double lumen catheter. You can see here we crossed into PLVB using a Fielder XTR through the double lumen catheter, and post that we stunted from distal RCA into PLVB, you can see, and this is a final result after IVUS guided optimization of stent expansion. Post PCI, we again measured his hemodynamics, and his MAP was 85 even after bringing flow down to P4, and lactates were around 2.2, which was equivalent to the pre-PCI levels, and urine output maintained, and also his right heart catheterization at P4 flow was showed similar pressures as pre-PCI with a CVP of 9. So that made us understand overall hemodynamics are okay. So we decided to wean off Impella immediately, and we closed the femoral access site with pot close. Yeah, in fact his residual syntax score was less than 4. That is, only ramus was untreated, rest all were treated. So, and you can see his MR, there was no MR post procedure, absolutely no MR, and you can also appreciate an improved LV function post procedure. So take home message from this case is hemodynamic support with Impella is the key savior in such patients with severe MR, LV dysfunction, and CTO interventions. Also LMCA bifurcation intervention. So instant CTO is favorable for antegrade wire escalation, directed tracking as a stunt acts as a marker for wire navigation. And ELCA came as a rescue in this case due to balloon uncrossability. In a balloon uncrossable situation, ELCA is a very simple option in such patients who are hemodynamically unstable. Thank you. So you can subscribe this channel to watch more and more such videos in future.